I'm going to present the update of CALGB SWOG 80405, and I would have to say, to be clear, that there is no dramatic findings that I'll present to you today. What I will do, though, is present the various sub-studies that we've moved forward, as well as talk about some of the newer data, a little bit of new data. This, as you've seen, I think 3 or 4 times this morning, this is the design of the CALGB SWOG 80405. Again, the choice of chemotherapy was that of the physician and the patient. About 3/4 of the patients received FOLFOX, and 1/4 received FOLFIRI. And again, this has been presented a year ago, and what I'll do is remind you, as you've seen already, that in the KRAS wild type, codons 12 and 13, the survival was 29.9 and 29.0 in the 2 arms, which is no different. And again, the work goes on. Now, since that presentation, in the United States, in the cooperative groups, we need to do a variety of things to move the data into manuscript and to do formal reports. We have to audit all the medical records, which is underway. We will be auditing 289 of the medical records completely for accuracy. We're going through a final data sweep right now, and the manuscript is in preparation. We've made the decision not to present new data, so more events have occurred. We could update the data with a few events in each arm, but I don't feel like that's particularly productive. So what I'll talk about now are some of the sub-studies we've done. Our steps now, we're distributing specimens for the correlative science, and we're doing a chart-by-chart collection of missing information. What I'll present to you today are things that have been presented, and one thing that has not been presented. I'll talk about the all-RAS analysis, which Heinz Lenz presented at ESMO last year. I'll talk about our sub-study of vitamin D by Kimi Ng that was presented at ASCO GI and at ASCO. GWAS data presented by Federico Innocenti at ASCO this year. A cost-effectiveness analysis done by Deb Schrag at ASCO this year. A pooling of the FIRE3 and 80405 data in a subset, which was presented at a poster at ASCO by Heinemann and O'Neill this year. And I'll say a word about disparities, which have not been presented yet. This is the all-RAS analysis that Heinz Lenz presented at ESMO in Madrid last year. These represent the different mutations that were seen with subsequent analysis. This represents about 2/3 of the patients analyzed on the study. And again, to emphasize, as we've shown before, with the all-RAS analysis in this study, there was no difference in the chemotherapy, cetuximab versus chemotherapy bevacizumab results. Really, each arm did better than had been seen in the KRAS-only wild-type study, which is consistent with excluding patients who had a poorer prognosis. Acknowledging that this is different from FIRE3, we'll talk about that in a bit. That's been the subject of a lot of discussion, of course. So this did not show the difference that was demonstrated earlier in FIRE3. Vitamin D is an interest of mine and a few of us in the U.S., and we prospectively collected vitamin D levels in patients on this study. This has been presented by Kimi Ng from the Dana-Farber. In our study the original study, the total study randomized 2,334 patients. As you'll recall, it morphed from a 3-arm study to a 2-arm study. A group of patients were excluded who'd received a double biologic, and some of whom were RAS mutant. So with that as a total sample size, we did vitamin D collection in the original cohort in many patients, and here's the data that Kimi has presented, which really I think shows, at least convincingly to me, now I actually believe vitamin D may be important, others might question this, but shows that there is a survival advantage in the baseline vitamin D level for patients who, as they presented with metastatic colorectal cancer. Here the curves are simplified to just 3 curves, grouping groups 1, 2, 3, and 4, and then the 5th group in yellow. And we see that the patients with higher baseline vitamin D levels had a better survival. It would turn out, of course, that fully 80% of all the patients on the study had insufficient vitamin D as it's measured in these days. But again, I think relatively strong evidence that vitamin D may matter. This, of course, doesn't tell us that repleting vitamin D in patients who are deficient for vitamin D will help. This is a baseline factor. Now, we did a multivariate analysis across many parameters, a dozen parameters, including RAS mutational status, the season of the blood draw, where the patient came from in the United States and Canada, that was whether it was a sun belt region or not, body mass index, physical activity, all of these were factored in, and they're still conferred an advantage for patients who had higher vitamin D levels. Again, we don't know that repleting vitamin D would be helpful, but this may be something we'll have to account for in future study designs in terms of baseline vitamin D levels. We did GWAS in a collaboration with the Riken group, and this was presented by Innocenti at ASCO, and in fact, side by side to the ASCO presentation was a FIRE-3 GWAS done by Heinz-Joseph Lenz. This was a collaboration with the Japanese investigators, and essentially we found 3 single nucleotide polymorphisms that appear to stand out. The one we're most interested in is the bottom one, axin 1, which interacts with the APC and beta-catenin pathway, and again, at least it's a common allele. It's a 30% allele frequency whose function is unknown, but when looking at both arms of the study, we found that this was a prognostic factor. That is, this SNP was prognostic for better outcome, both in the bevacizumab arm as well as in the cetuximab arm. Again, this remains to be seen what the function of this is, and GWAS analysis is always has to be carefully interpreted because of the number of findings and the possibility of coincidental findings. But this, we believe, may be relevant, and we're following up on the axin 1. I think a very important question that came up at ASCO and that we need to talk about is an economic analysis of 80405, and this was presented by Deb Schrag. Again, this was a pre-planned economic analysis. Now, in 80405, at least, where there was no difference in outcome between the two arms, this is not a cost-effectiveness study per se because both arms had the same result. This is really an economic analysis looking at utilization of resources. I should say that there was a paper in JCO a few months ago by Dan Goldstein who did an analysis of the cost-effectiveness of bevacizumab in colorectal cancer, and by his analysis, the cost of a quality-adjusted life year was $550,000 US, which is about 15 times what would be considered an acceptable quality value. So whether it's a value or not is not the issue here. This is a comparative cost. The rationale being if the two arms are the same, the cost might be something that needs to be considered. And in the U.S., this is now just gaining traction. Again, this is cost minimization is preferred when the effectiveness was the same in the studies. And here we see the difference in cost. It's about $40,000 more costly cetuximab versus bevacizumab. Some of that has to do with the frequency of infusion. Cetuximab given every 3 out of 4 weeks, bevacizumab 2 out of 4 weeks, and the cost of the drugs. So were we to make a decision, if we believe that these are equivalent treatments for cost effectiveness, we would prefer the bevacizumab to cetuximab. Many issues being still have to be discussed. Quality of life was also analyzed, as you recall, in the study. There was no global difference in quality of life, although the cetuximab patients had a far inferior sense of well-being because of their rash. Finally, I'll just say a word about race. In the United States, this is a very important and timely question. That is, 221 of the patients included in the overall study were African American. It's been observed for many years that African Americans in the United States do not do as well with a cancer diagnosis as non-African Americans. And the debate has always been, is this because of access to care or because of the biology of the cancer in African Americans? And at least in this analysis, which is not complete, and so this is preliminary data, we saw no difference in outcome amongst African Americans and non-African Americans, suggesting that it may very well be access to care in the United States that affects the inferior results for these patients. Again, this is preliminary data that we're still working on to be corrected for other factors. Well, what I'd like to finish on is I know people have had free rein to talk about 80405 and compare it to FIRE 3. I'll give my spin on this, and that is what's common and what isn't. These are the different mutations that were found in the all-RAS analysis, so there's a slight difference in the percentage of each mutation. In fact, there was a difference in the techniques used. For 80405, we used a somewhat lower threshold for declaring mutations, but again, more or less the same number of mutations, but represented different exons. Whether that's significant or not, don't know. I do think it's worth commenting on a pooled analysis that we presented at ASCO this year from the groups. Volker Heinemann and Bert O'Neill were the co-presenters. And these are in patients who had failed FOLFOX adjuvant therapy. In 80405, the patients who were on FOLFIRI, many of them had failed adjuvant chemotherapy. And here you see the results. The patients who randomized to FOLFIRI cetuximab versus FOLFIRI bevacizumab, those who went on bevacizumab had a 41-month median survival compared to those who went on cetuximab. Again, a small subset. By definition, patients could go on study if they'd failed more than 12 months after the completion of their FOLFOX adjuvant. Despite the fact that FIRE 3 had inverse results in terms of the overall survival, these are the same population of patients, similar numbers, who received FOLFIRI Cetux or FOLFIRI Bev in the FIRE 3, failing FOLFOX adjuvant. In this case, it could have been within anything greater than 6 months from the therapy. And you see, similarly, there's a much greater survival. There's a survival, apparently numerical superior survival in the patients who received bevacizumab compared to those who received cetuximab. Here are the features of the patients. So the 80405 patients slightly younger. Again, this male-female distribution the same. And if we sum the data, we see that it does not quite reach statistical significance, but a suggestion that patients getting FOLFIRI bevacizumab may do better than patients getting FOLFIRI cetuximab if they progressed on FOLFOX adjuvant. The genesis of this, the basis of this, is something we're exploring. In 80405, we have plasma for patients when they come on study, and we're looking for circulating DNA to see if there's perhaps been a RAS mutation that has evolved in those patients, and more work to be done. Again, in contrast, as was shown earlier today, I would just emphasize that the real difference between FIRE 3 and 80405 sits in the bevacizumab arms. And in this, the all-RAS analysis, the inferior result of FIRE 3 in terms of the FOLFIRI Bev versus the 80405 study. And the reason for that is something we are exploring and we'll speculate about in perhaps forever. I'm not sure we'll ever get to the right answer. Finally, we have other work to do, a lot of work to do. Again, I'm not happy to report that we've been unable to complete the data sweep or refine the data yet. We're working on it. It's out of my hands. It's actually been in the cooperative group's hands, and we've been unable to complete it. So a lot of work to do, and hopefully in the next 3 to 6 months we'll have a manuscript, and we'll be able to fill in a lot of the blanks that you appropriately are waiting for us to fill in. Thanks for your attention.